Hello and welcome to our Research in Progress webinar series. I'm Carrington Lott. I'm the program manager for the Systems for Action research project, our research team. If you're not familiar with Systems for Action, we are a national research program of the Robert Wood Johnson Foundation, and we're housed at the Colorado School of Public Health. And we support research nationally that focuses on facilitating collaboration between the public health, the social service, and medical systems with the goal of improving health equity and population health. Today, we are joined by our team Benefits Data Trust located in Philadelphia. They're part of our third cohort of research teams, and they're going to be wrapping up their project in 2021. And their research is focused on connecting vulnerable seniors to nutrition assistance. So today we'll hear from Jamila McLean and Suzanne Kinski, and they'll present on their research, and then we'll hear a quick commentary from Joan Eichner. And at the end of the commentary and the research presentation, we'll have dedicated time for a Q&A section. So if you have any questions that pop up as they're presenting, please use the Q&A feature down at the bottom of your screen. And to introduce our people who will be presenting today, we have Jamila McLean. She is a manager or policy manager at the Benefits Data Trust. We have Suzanne Kinski, who is the Director of Research Translation and Capacity Building at UPMC Center for High Value Healthcare. And we have Joan Eichner, who is the Program Administrator with the Center for High Value Healthcare. And with that, I'm going to hand it over to our team so we can hear what they have to share.
Fantastic, thank you. This is Suzanne speaking. I think Jamila and I will mostly share a presentation of these slides throughout the entire presentation, but we're going to start by giving you an overview of community health choices, the UPMC Center for High Value Healthcare and Benefits Data Trust, briefly review our research design, but then we'd really like to spend some time outlining what we think might be the impact of COVID-19 on our study progress so far and what the implications of this work might be. So if we want to move to the next slide. Let me give you a quick overview of what community health choices is. Community health choices is long-term services and supports for Pennsylvania residents. Several years ago, Pennsylvania decided to move to managed care for this benefit. So basically, if you live in Pennsylvania, you're 21 or older, you have both Medicare and Medicaid, or you receive long-term supports through Medicaid because you need help with everyday personal tasks, you're covered by the Community Health Choices benefit. So it provides primary medical coverage for people who live in nursing homes, for people who are on those home and community-based services waivers, who don't have Medicare but are eligible for Medicaid. It could include people who who are custodial nursing home residents, provides ongoing support for them, and then also provides support in the community for people whose health status means that they would qualify for nursing home eligibility, but they're still living in the community. So full disclosure, I am not a member of the CHC team. There's a lot more minute nuances that I'll do my best to explain. For those who attended our presentation, which was I think exactly a year ago, we actually provided a bit more detail in this by a member of our CHC team. So this is sort of a high-level summary, but I would be more than happy to get you more information if you want. So next slide. So CHC is broken down into what we call 3 zones, or actually multiple zones, but 3 rollout phases. And so Pennsylvania staggered the rollout of managed care, starting with the Southwest version. So that's where Pittsburgh is located, and that was rolled out in 2018. Next was 2019, which was this tiny little chip in the Southeast, but it's actually quite large in terms of population because that's where Philadelphia is located. And then what was most recently rolled out is the section in the middle, in the like the light blue, which is the Northwest, Northeast, and the Lehigh Capital region. Because it roughly looks like a T, that is sort of our shorthand, the T. So it's a fairly large population and was the last to roll out. Next slide. Where it stands right now is we have a little over 100,000 members. We had a big jump at the beginning of this year when we went to the T. But so most of our membership is considered dual, which means that they receive both Medicare and Medicaid benefits. You'll see there's just a tiny proportion of people that are on a Medicaid waiver but are not receiving Medicare. Because UPMC is an insurer across all insurance products, we have a slice of the population that we consider to be full risk, meaning that we provide both their medical care insurance as well as their long-term services and supports insurance. And so that's about a third of the population. And then the remainder are people who have us for their Community Health Choices product, but have a different Medicare and or Medicaid insurer. Now that we have rolled out to the T, we're geographically across the entire state. Again, about a third of it is in the Southwest, but we're now serving all Pennsylvania individuals, along with 2 other insurers that are also providing CHC benefits. And then we also tend to break down our membership in terms of their long-term services and support status, by which we mean there's a small group of people in the orange, about 12%, who are currently residing in a nursing facility. And then another 20% have a health status that means that they qualify for nursing facility care, but they're still living in the community. And then the remainder, about 2/3, are not yet eligible for a nursing facility. So lots of folks are dually eligible for both Medicare and Medicaid, also referred to as special needs plans. If you are dually eligible, you are automatically enrolled in CHC, even if you don't need long-term services and supports yet. So everyone's goal is to keep people healthy and not needing nursing facility level care, whether that's in the community or a facility. And then for folks who are living in a nursing facility, obviously our goal is to work with them based on their choices and help them transition back to the community if they can. Next slide. So that was sort of an overview of like the context of the move to managed care and UPMC's part in it. And then where Joan and I are employed is called the UPMC Center for High Value Healthcare. We're almost 10 years old, and we're a nonprofit research organization that operates under the umbrella of the whole insurance services division. And so our goal is to do research, externally funded research on different and innovative models of care, support our own clinical and business services through rapid cycle evaluation and learning, and then broadly disseminate findings. And because we are sort of the research entity, that's how BDT approached us when they wanted to partner with us to do an evaluation of our partnership together relative to SNAP benefits. And I think now I will turn it over, to Jamila to talk about BDT.
Thanks, Suzanne. And hello again, everyone. As mentioned earlier, my name is Jamila McLean, and I am the Healthcare Policy Manager at Benefits Data Trust. And so today I'll be sharing a high-level overview of BDT, our work, our model, and how we've partnered with UPMC to support their community health choices members, so that dual eligible population. So for those of you who are not familiar with BDT, we are a national nonprofit organization committed to helping people live healthier, more independent lives. And we do this by helping to break down the barriers to public benefits access. Our mission is to connect those who are eligible for public benefits programs to them. And we do this at scale by using the 4 pillars of our model, which you see here. We are a true population health approach that is first and foremost data-driven. And by that, I mean that we use federal, state, and local data to identify individuals that are likely eligible but not enrolled in benefits like SNAP, LIHEAP, or energy assistance in Medicaid. We then use these highly targeted lists to conduct multi-channel outreach, so via calls, texts, and mail to those that we've identified as eligible but not enrolled. We operate a person-centered contact center. So when we get in contact with these folks, we provide comprehensive application assistance for the benefits that I just listed so that we can meet our clients where they are. And finally, our work is completely outcomes driven. So we again use data to track enrollment outcomes to really assess the impact of our model and to focus on the most impactful interventions. There we go. And so that brings us to our partnership with UPMC, and more specifically, this collaboration with the UPMC Center for High Value Healthcare to understand the utilization and cost impact of enrolling their dual eligible members in SNAP. BDT had been having conversations with UPMC for several years, but in 2018, we formalized a partnership with UPMC to enroll their dual eligible population in SNAP. And we are doing that by matching the UPMC member list with data from the state to identify individuals who are enrolled in Medicaid but not enrolled in SNAP, and conducting that targeted outreach and application assistance that I described in the previous slide. And before I pass things back to Suzanne, who's really going to dig into what we're all here for, which is the research and really understanding the outcomes of this intervention, I wanted to really center why this work is important and show the impact of BDT's outreach thus far. So again, these numbers really may be familiar to a lot of folks on the phone. And if you joined us at the previous webinar last year, you've probably seen this. But again, helping people access public benefits is a proven way of improving health and cost outcomes. It's been shown through previous research that the likelihood of hospitalization decreases by 14%, nursing home utilization by 23%, and it can save over $2,100 in healthcare costs for each older individual that's enrolled. And we are really hoping that this work, this collaboration between BDT and UPMC can really contribute to this growing body of research. And finally, for this study to date, BDT has submitted over 700 SNAP applications for the UPMC dual eligible population and provided application assistance and or referrals for additional benefits such as LIHEAP, such as prescription assistance and WIC. And now I will turn it back to Suzanne, who's going to dive into the research.
Awesome. So again, those who were at our last presentation have seen this already, but I'll just briefly review it. We're capitalizing on the fact that BDT cannot reach out to every single CHC member on the first day. And so what we decided to do is a waitlist design. Every month, the UPMC sends BDT a list of eligible CHC members, and then BDT combs through it, determines who already has SNAP benefits, and then performs outreach to the remainder. And so eligibility is any CHC member who is not currently living in a nursing facility and who's not currently receiving SNAP benefits. So we decided to select a group for what we're calling immediate outreach, which has been the cohort that BDT has been conducting outreach to for the past year. And then there's a cohort selected for delayed outreach, who will wait to get outreach from BDT until after we're finished with our primary outreach. And this is really because there's a cap on the number of people that BDT can reach out to on a given month anyway. And so if we apply a little randomization, we might eliminate some potential bias that is inherent in a lot of SNAP research. So our primary independent variable is SNAP enrollment. What our goal is to look at the individuals that have received BDT outreach and determine of those who received SNAP. And then using propensity score matching, match in a 2-to-1 manner to the individuals who make up the cohort for delayed outreach. So we are conservatively estimating that there will be about 600 people at the end who wind up getting enrolled in SNAP benefits. And then we will select about 300 of those for a propensity score matched comparison group sample. And our primary outcome of interest is hospital utilization. So we can go to the next slide. So our research really hinges on knowing who obtained SNAP, who enrolled in SNAP at the end of this. So our team here at UPMC has worked really hard to set an agreement with the PA Department of Human Services to allow us to learn SNAP enrollment info on our members. That agreement was actually just reached, and we got data this week, which if you've ever negotiated a legal agreement with a government entity, I'm sure you can tell us what a victory that is. And it has taken an extraordinarily long time to get it. In addition to our primary outcome of hospitalization, we also have several secondary outcomes. So for all of our members who are covered with our own medical product, we can see all of this data. We know also that we have data on utilization, a subset of utilization data for members who have a different Medicare or Medicaid product, or a different Medicaid product from the state. But since we just got the data this week, we need to dig into it to determine exactly how granular that is. I'm fairly confident that we will have the full set of data on all of the utilization variables, but whether it's as detailed to be able to tell some of the quality really remains to be seen. It's one of the challenges of the length of time that it took to get this agreement is that some of this is still a little bit to be determined, but I don't anticipate having any problem on hospital utilization, which really is our primary outcome. Next slide. So our project timeline indicates that we are just wrapping up what is sort of our primary activity, which is doing the outreach and SNAP enrollment to the CHC members. What we would like to do is look at our hospital utilization in the 12 months prior to receipt of SNAP benefits and compare it to the 12 months after receipt of SNAP benefits. So now we are sort of in the observation period for most of our members who have enrolled in SNAP benefits, and that will end about this time next year. And then we'll spend the next couple of months doing wrap up. Next slide. So now I'd love to talk about the impact of COVID-19 on our study to the extent that we understand it right now. But I might turn this over to Jamila or Rachel to talk about policy changes impacting food security.
Thanks, Suzanne. And we knew that we could not have this presentation without talking about the impact of COVID-19, particularly on the policy changes with the Supplemental Nutrition Assistance Program and Medicaid. And as most of you are probably familiar, that the federal government really acted quickly to provide states with a lot of flexibility to the SNAP program so that they could respond to this crisis. So which led to the Family First Coronavirus Response Act. And that provided both USDA and states with a lot of temporary procedures to make it easier for folks to participate and or apply for SNAP. And we've listed some of those flexibilities here, including suspending the 3-month time limit on benefits for unemployed adults under the age of 50 without children in their home, as well as including increased SNAP benefits for households who had not yet reached the maximum, and expediting online purchasing pilots, extending certification periods, and adjusting the reporting requirements, as well as waiving other requirements such as the application interview. So these were all factors that we had to take into consideration when looking at how this would impact the outcomes of our study. And I'm going to go to the next slide.
So some additional impacts that relate to healthcare. One is that the population of our CHC enrollees may have shifted this year due to changes in how eligibility is determined or redetermined. So meaning who gets termed, who gets enrolled or disenrolled. The section of the state called the T was added right before COVID hit. And it's possible that many of those members would have normally termed due to, they didn't meet the eligibility criteria anymore, but remained in our product, remained in CHC. for a longer period of time, and that might fundamentally impact the population. That would also apply to anyone in the phase 1 or phase 2 expansion. But the T was quite a large population add. That said, because it came so late in our outreach period, it's really to be determined if it's going to make a big change to the makeup of the study. It's something that we will have to continue to monitor as these temporary policies continue to happen. But what is perhaps more important are the other potential impacts listed here. So first, we have documented changes in healthcare utilization that occurred when COVID really hit and everyone went into lockdown in mid-March. So in our population as a whole, which is not just CHC, but anyone with medical insurance, we are observing that emergency department visits took a noticeable dip. We look at condition-specific populations. For several populations that have chronic conditions, we're not seeing the level of ED visits that we would normally if we look at the 2019 and 2018. However, it's not really clear if hospitalizations had a similar dip. Data, again, there's a claims lag, so it takes several months for claims to be finalized. So data, again, is still rolling in and we're still really trying to dig into it and determine, but perhaps people were utilizing the hospital at the same rate, but instead of entering through the emergency department, they were going in through doctor's recommendations and being admitted directly. Maybe that's the reason, but again, there's a lot that's still TBD. But obviously that would impact, because that is our primary outcome, that would impact that measure, and it would also impact several secondary measures. In addition, we're noticing that there is a dramatic uptick in the use of telemedicine for care, but I don't have data yet on how our CHC population was affected relative to the rest of our membership. And then the last major impact of COVID was sort of similar to what Jamila presented about SNAP benefits, is that Medicaid has also loosened and changed their eligibility benefits. So this is not an exhaustive list. Actually, Kaiser Family Foundation has a really great website where it has tracked all state policy changes relative to Medicaid. But examples would be they've extended the redetermination period so that people can retain their eligibility. The types of documentation and the requirements for proving residence or eligibility has been revised or loosened or extended. There's been a shift in benefits and what drugs make up the formulary for the preferred drug lists. And then they've modified processes for level of care evaluations or reevaluations. So all of these shifts, which continue to happen, may have an impact on our cohort of individuals who are in the study. Next slide.
So this is Joan Eichner, and I am going to talk a little bit about some of the broader implications of this study and why, from the payer perspective, this is something that UPMC is really interested in. So I'm sure everybody is familiar with the statistic that is, really popular in health right now, where up to 80% of health outcomes are linked to what happens outside of sort of the traditional healthcare space. So to that end, payers and healthcare systems are really looking for innovative ways to begin to address their member and patient social needs and to, recoup cost savings or begin to see positive changes in utilization and health outcomes associated with meeting those social needs. So the UPMC health plan created what we call the Center for Social Impact in December of 2019. And what that organization is, which is housed within the Center for High Value Healthcare, where Suzanne and I sit, is really meant to be a clearinghouse for all of the health plans work around social determinants. And it's a place where we can really leverage the space of UPMC's integrated payer and provider system to pilot, test, and scale different innovations around member social needs that may have health impacts. So, we are really looking closely at research and best practices and trying to understand, which social interventions are most likely to lead us to the type of outcomes that we hope to see as a health system and specifically as a payer? And how can we do a lot of this work with really high quality community-based partners such as BDT? We know from social intervention literature that's out there that, it's a really emerging field of literature and evaluation. There's not a lot of very high quality or robust study designs in the social intervention space. And that's one limitation, but it's also really tricky to kind of generalize findings across different evaluations and studies to really have a strong kind of takeaway of where the body of research stands. For example, food interventions, there's a growing body of research specifically on them in healthcare settings around either directly providing food or access to benefit enrollment or providing, for example, vouchers to purchase food in other settings. But it can be really difficult to kind of assess what the member level health outcomes or impacts around care and utilization might be. Those are typically longer term outcomes that are not necessarily able to be well evaluated in some of the studies that are out there. We also know that benefits enrollment, such as where BDT is an expert in, has really been associated with all of the things that Jamila and Suzanne noted earlier around improved condition management and nursing facility deferral and improved cost and utilization. So that is really why, from the payer perspective, UPMC was eager to work with UPMC. There's, I think, stronger and more rigorous evaluation data in support of BDT's work than many other types of social needs interventions. And as was mentioned earlier, one of the biggest challenges, but also areas of opportunity for this project was looking at data sharing arrangements between health and human service systems or other sort of cross-industry data sharing arrangements and how that interoperability can raise challenges to doing this type of innovative work. So as Suzanne mentioned, it took us quite a long time to get an executed data sharing arrangement with our state Department of Human Services to allow us to see the SNAP data and the complete Medicaid utilization data that we needed for this evaluation study. But, this is something that we, and I'm sure many other health systems, are really interested in doing and putting the work in, because these types of data sharing arrangements really allow us to do some innovative evaluation work and really allow us to do more comprehensive targeting of interventions and evaluations around our members' health and provide more holistic care coordination for our members as well. And these types of arrangements really are mutually beneficial. In addition to this data sharing arrangement around the SNAP data at the state level, UPMC also has a data sharing arrangement with our county Department of Human Services, where we're headquartered, in which we are able to share complete member data with on anyone who is also in our county's human service data warehouse, which is a very comprehensive warehouse of human services, basically from birth to end of life. And this is a really innovative arrangement that allows us to serve our mutual clients in a much more holistic way by, partnering their human service coordinators with our care managers and really being able to wrap around health and human service needs of the members in these programs. So I just wanted to highlight these as a few sort of broader implications of this research study and others that we are beginning to work on. And I'd be happy to answer any more detailed questions about any of those as they arise. So thanks.
Okay, so that brings us to our Q&A section. Thank you so much for presenting on your research, guys. That was fantastic, and I really appreciate you being so open and honest about how COVID has impacted your research and how you're having to be adaptable, because I imagine many of us are in that same situation right now. So if anyone has any questions, I invite you to please use the Q&A feature at the bottom of your screen and submit your questions to us. And it looks like we have a question from John. He says, you find contact eligibles. What is bias in those that work with you to get benefits? Is it possible to some who need it most don't get back to you?
Yeah, I can address that and then maybe ask my BDT colleagues to provide insight from their experience, but that's sort of a perpetual challenge with this type of research is, as a healthcare services researcher, this is very similar to when we're trying to figure out how to get people to access more preventive services, right? That there's some bias, there's a self-selection of folks who are more willing than others to engage in whatever we want them to engage in, whether it's applying for SNAP benefits or giving a flu shot, that kind of thing. Our hope is that by applying a little bit more rigor to the selection of the cohort, that we might be able to account for some of that self-selection bias.
Great, thank you. And it looks like John actually has another question. So he says, HbA1c is affected by so many variables. How can you assess how much changes might be attributable to the intervention?
Oh, yeah. No, I mean, you're right. When we were designing this study and we were talking about what other things could we potentially measure, we talked to some stakeholders here within the CHC product and our health plan, and quality measures. So these are HEDIS measures that we are accountable to. They identified the HbA1c ones as ones that would be of interest in that, we're perpetually trying to close those gaps, but then also the receipt of SNAP benefits could, conceptually have an impact on that because it would increase individuals' access to healthy food, decrease food insecurity, which in turn could improve quality of diet and maintain control of diabetes for individuals with diabetes. Are we going to be able to say that receipt of SNAP benefits was the reason that someone's A1C went under control? Probably not. I think it would be an interesting signal to us. Keep in mind that, UPMC is approaching this as a health insurer who traditionally health insurers have really only taken control of the medical care aspect of the equation without touching the social piece, as Joan was saying. So whether we as a payer continue to invest in social determinants of health in this way might not need, a definitive link between SNAP enrollment and improving our HEDIS measures, right? Like we don't necessarily need, I would argue, and I would welcome others' thoughts. I would argue that we don't necessarily need to prove that one thing causes the other. An association might be enough for us to be able to make the business case that this is just smart to do. I don't know. I hope that answered the question.
Yes, I think that was great. Thank you, Suzanne. Let's see, Scott would like to know more about your local Department of Social Services and their willingness to share a list of who was on SNAP. They want to increase SNAP enrollment in his location, but they cannot figure out a way to find out if patients they recommend for SNAP are actually following through.
So I can take this, but others please jump in if you have thoughts to share. So how it worked for us was our Pennsylvania Department of Human Services already has a business associate agreement in place with UPMC Health Plan as our Medicaid MCO. And they also receive and administer the SNAP program. So a lot of the challenge in creating sort of a data use agreement between these entities, which were all covered entities, was really determining whether SNAP enrollment information was protected health information and what type of agreement we needed to have and for what purpose we were sharing the data. So, I mean, the short answer is it took, several calls between the legal team at PA Department of Human Services and UPMC to figure out the legalese of how to actually execute an agreement. But at the end of the day, it comes down to, at least in our situation, the Department of Human Services was willing to provide SNAP enrollment information as well as the level of the SNAP monthly benefit because it was under the purposes of Department of Human Services administering the SNAP program and Medicaid. We had to make sure that we were wording our request that UPMC is doing this evaluation to help PADHS understand SNAP utilization as within their role of administering the program, not that UPMC was doing this evaluation study for a self-serving purpose. And there was also sort of some nuances and legalese around, who owns the data, who can publish on the data, and who has approvals for that data, and what can be put out there in the public space. So it gets sort of complicated, but that is sort of the gist of how we got to the data sharing arrangement.
And this is Rachel Cahill from the BDT research team. I'm a consultant that has supported this work. And I did just add a little bit to what Joan said, because there's a long history of BDT working collaboratively with the Department of Human Services in Pennsylvania on data share agreements around SNAP. So there's some good lessons learned, I think, for folks in the healthcare space as well as in the nonprofit space about how these agreements can be done. But one thing that Joan said, just worth highlighting, is it's critical from the data use perspective to show that enrollment in SNAP furthers the purpose of the Medicaid program. So it's in the interest of the state recognizes that it's in the interest of Medicaid to see better nutrition reach Medicaid recipients. And so that's a linchpin in agreements. If you can't just do it for the purpose of furthering SNAP enrollment, it has to benefit Medicaid, which is how UPMC and BDT in an ongoing way is able to access some of this data.
Fantastic. Thank you, Rachel and Joan, for answering that. I'm going to kind of piggyback on that. We had a question that was submitted through the chat feature. And you did just kind of talk about, lessons learned and best practices there. But if this model proves to work, what will be involved in scaling it up to other systems? And what are you learning about the best ways to get systems to work together?
Sure, and this is Jamila. I'm sorry, I just cut somebody off.
No, go ahead, Jamila.
Yeah, sorry, this is Jamila BDT. And I was just gonna say that's a great question. And I think it goes back to kind of like building off of the previous points about the complexities of data sharing and working across data systems, particularly when you consider the fact that we're looking, each state can be slightly different. We know that once you've seen one Medicaid program, you've seen one Medicaid program. So really taking into account the time it takes to understand how these different public benefits and these public programs operate within specific states, and whether or not they're administered at the state level, the county level, the federal level, and really figuring out how all these programs and systems work together. So there is definitely the opportunity for these programs to be integrated and to work together to ensure that folks that are eligible for public benefits are able to get access to all of the benefits that they are eligible for. But it certainly takes work. And I don't know if Joan or Suzanne or Rachel wanted to build on that.
This is Rachel. I'll just add that I do think depending on what this is that we're talking about, right? I think this project partnering with a payer is especially unique, right? Because as Joan mentioned, you're talking about an interested party who has a business interest in healthcare, just putting it that way. Is different than partnerships with enrollment entities like BDT. So, BDT has partnerships, operates in multiple states and has partnerships with state agencies in multiple states where they do data sharing for the purposes of enrolling folks into SNAP and other benefits with an emphasis on seniors. And those, as much as complex as those arrangements are, they're actually quite a bit simpler than this one was, because we were adding a layer of a payer at the table. But of course, as Suzanne said so well, having a payer at the table, takes us from theory to action, right? It takes us to, is this meaningful? Are the findings meaningful enough that a payer will actually invest in this intervention? Is the evidence good enough for them, instead of the field putting out research on hypothetical interventions, right, that might matter to payers. So I think it's been exciting in that way.
Great, thank you for addressing that. YL, I hope I'm saying your name right, would like to know, are there similar initiatives in other states and do they have the same challenges?
Right, and I think that's what I was just kind of thinking about in terms of, Jamila, you can tell me how many states it is now, 7 or something states that BDT is in, working on multiple programs. Go ahead.
Yeah, so BDT is currently in 6 states doing this direct kind of outreach and enrollment work. There are definitely differences by states in terms of what benefits we are able to provide support for. So I think that can be some of the challenges. So just getting started up in a state in terms of figuring out what benefits we would be providing outreach for, as well as what types of data or what data sources we have access to. So again, going back to Rachel and Joan and Suzanne's point about working with a payer and being able to have access to their data, as well as state data and other local or state or federal sources.
Thank you, Jamila. Let's see, Douglas would like to know about impediments to state and federal governments adopting these policies and becoming proactive to enroll those seniors that qualify for SNAP benefits.
Jamila, do you want me to take this one, or do you want to?
Yeah, I was just gonna say, Rachel, I feel like you have a lot of expertise on this.
Sure. Well, this is an area that's been growing. There's been a lot of activity in the last couple of years as this research base has grown, showing the benefits of SNAP in particular for seniors' well-being and their healthcare utilization. So there are a number of things that state and the federal government, but states especially, can do. I won't go through all of them, but a couple of big simplifications are essentially extending enrollment periods. So there are some states who can keep a senior enrolled for all the way up to 3 years before requiring them to do more paperwork to re-enroll. But most states require it much more frequently. And we know that falling off the program in that way, causes harm, the same way that falling off of Medicaid and churning on and off of the programs causes harm. So there are a number of waivers that are packaged together under a project called the Elderly Simplified Enrollment Project, which BDT has done a lot of work on to get more states to take that up. There's a lot further that the federal government could go if an administration so chose to do it. And also, the benefit level matters a lot. So if in the medical sense, we think of it as dosing, right? The higher the dose, the higher the SNAP benefit, the bigger the impact. And right now, while most senior households get, about $120 is like the average SNAP benefit per month that a senior household would get, some get as low as, $16, which is a minimum benefit. And right now, because of COVID, everyone is receiving the maximum benefit, which is a huge increase in the resource. So one of the things I'm looking forward to seeing the results of this study is whether that big boost in the dose of SNAP that COVID, the COVID relief packages are providing, whether we see, a meaningful impact in their healthcare and their well-being because of it. So that's a long-term change that I'd love to see after this COVID mess is over, because we think it has such a big impact on seniors.
Terrific, thank you for addressing that. Juana would like to know, so he's a student at the University of Belize, and they'd like to know what are some of the important changes healthcare had because of COVID-19, which you did touch on this a little bit in your research presentation, and then you just talked about a little bit in your last answer. But if there's anything that you didn't cover about, how healthcare has been impacted and how that's impacting your project, and you'd like to discuss it now, please do so.
Yeah, I mean, one of the major changes was due to infection control, people were advised to not go to the ED unless they absolutely had to. a lot of, at least the UPMC providers that we have, stopped scheduling and canceled elective surgeries for a period of time, for several weeks until the initial risk was over. A lot of medical appointments where you would normally go into a hospital or into a physician's office in order to see them in person transition to online. So one concern is, which again, we're still sifting through the data to determine the severity of this, is that there may have been a cohort of people who just avoided care out of fear of infection, reasonable fear of infection. For folks with chronic conditions who require ongoing monitoring, ongoing prescriptions, the question is, did they get to those appointments? Did they get that needed care, or did they just skip it? Did they feel comfortable going to their pharmacy to refill their prescription? Or were they able to get the pharmacy to deliver it to their home? Or did they feel that that was too much of a hassle? So there's sort of the downstream sequelae or consequences of being infected with COVID, but there's also these downstream effects of having a different chronic condition, but due to interruption in care, a potential worsening of your healthcare condition. And that's going to take some time for us to observe those changes. And then the other large change was this transition to online. So telemedicine has always been an option that had relatively low uptake. And some of that was because the people who were making use of it were individuals who, excuse my barking dog, who had savvy and access to the particular smartphone apps and were willing to go on a web browser and do the video chat and felt more comfortable doing that. And you had then providers on the other end that were okay with that. But what we saw after COVID is that providers were saying, do not come to the office. We will only interact with you online. And so that really forced this massive uptake of telemedicine. At the same time, there were benefit changes that were happening that where telemedicine visits would have previously not been covered were suddenly waivered to be able to be covered, at least temporarily. And there's a lot of discussion about at the state and national level about policies related to benefit design and what should we cover in terms of virtual care long-term versus what should only be temporary. I think a lot of that will kind of shift, and we're currently looking into, is the quality of care that's delivered through a computer screen the same as when somebody is like sitting on an exam table face-to-face with your doctor. So that's just sort of an example of some of the major changes here in the US.
Thank you for expanding on that, Suzanne. Vanessa would like to know, if you break down the cost of the program, I'm assuming most of it goes to outreach. How were you able to justify this with the funder? They had some difficulties to ensure the outreach is covered, not only enrollment is covered.
Yeah, and this is Jamila again. I think that kind of goes back to one of the slides that I presented on that really showcased the impact of this work and this type of intervention on actual health outcomes and the cost of health outcomes, and noting that simply participating in SNAP can result in over $2,000 of healthcare cost savings is really impactful. And also speaking to some of the work that BDG does when working with managed care organizations, what we also help provide is redeterminations for their managed care population. So we would send out text reminders to the Medicaid population, letting them know, hey, you're up for redetermination soon. Make sure you fill out your form so that you can keep your Medicaid insurance coverage. And that is really important for the MCOs because of that per member per month arrangement. So they're able to retain those member months. So in addition to the cost savings of actually participating in SNAP, there are also additional savings for ensuring that members don't churn off of Medicaid because they don't complete the renewal forms. So those are just some examples of the ways in which, just a simple intervention of making sure folks are applied for and enrolled in their eligible benefits can really result in some tangible cost saving outcomes.
And I would add to that, this is Joan, that, from the payer perspective, it's beneficial to us in the sense that even if a lot of the costs that we would pay to work with BDT would go to outreach, it's still, you know, that potential ROI is still valuable enough to us to make sense to pay a third party for that type of outreach. And BDT brings, you know, a lot of very specific expertise in research-based and practice-based experience in how to do the specific type of outreach and the different methods that they use and the different, you know, materials that they do, and, you know, their extensive online tools that they use. So for that perspective, it's really been a valuable partnership for us to explore.
Great, thank you. So it looks like Rachel runs a food prescription program that provides locally grown produce boxes to older adults. Have you found ways for older adults to use their SNAP benefits to pay for these boxes? And if so, what process did you use for the payment?
Hi, this is Rachel Cahill, and I was just looking at this question. It's a great question. I know there's a lot of interest in healthcare, from healthcare providers and from senior service organizations around the country to do this kind of innovation, especially in the time of COVID, when folks are avoiding the grocery store. There has been a lot of opportunity to do online shopping, which is new, but even so, produce boxes, you know, are a good example of why we need other mechanisms, right? The short answer is that basically you need to be a SNAP retailer to accept SNAP payment. And that is a process that goes through the USDA, the U.S. Department of Agriculture. I'm not aware of any healthcare providers who are are considered retailers and have gotten that approval, but I'd love to know if anyone on the line is and wants to chat. I also know of a health system in Ohio that is really innovative and is thinking about doing this. So I'm happy to make some connections for anyone else who's interested, after this call.
Thank you, Rachel. It looks like we have one last question. It seems like a pretty easy one here from Roland. He would like for you to repeat the name of the waiver for seniors to have extended enrollment time in Medicare.
Oh, sure. Yeah. So actually, if you're referring to the thing I mentioned earlier, I was talking about extended enrollment in SNAP and food assistance. So right now, seniors are typically enrolled for 24 months, so for 2 years, but have an interim report that's due at 12 months. So basically every year there's some paperwork that they have to do to keep their SNAP benefits. And that doesn't always align with when they renew their Medicaid, and that's totally separate from the re-enrollment process in Medicare that happens annually. So, it's hard, as you can imagine. It's hard for us to keep track of it. It's certainly hard for older adults to keep track of these different renewal periods. So as much as possible, extending renewal periods without having to wait for paperwork is what we want to see. And so the SNAP waiver that I'm talking about is called, the package of waivers is called the Elderly Simplified Application Project. And it's actually like a handful of different sort of wonky SNAP waivers that states have been using to extend to 36 months, so to 3 years for the SNAP enrollment period.
Great, thank you so much, Rachel. So that brings us to the end of our Q&A section. I'd like to thank our research team again for presenting on their project, and we look forward to learning more as your research progresses. So we do offer a certificate of completion, and we will have a quick survey that'll be activated as soon as this webinar is over. So please fill that out and let us know if you'd like a certificate of completion, and we can email that to you. We also will be emailing out the recording to this webinar, as well as the research team slides. And we'll offer another opportunity for you to fill out that survey if you miss it after this webinar. And this is an ongoing series of research in progress webinars. So we have another research team presenting on October 28th on closing the gaps in health and social services for local income pregnant women. And then on November 11th, we have a research team presenting on subsidized transportation options to slow down diabetes progression. So we look forward to having you join us for those. And like I said in the very beginning, we are a national program office of the Robert Wood Johnson Foundation, so we always like to acknowledge them. And that brings us to the end of our presentation. So thank you so much for joining us today.